Actually speaking, chest pain is one of the very common presentations to the ED, and we all see chest pain patients every day. But what I am going to talk is probably nothing new, but what we see, what I see, and what you see in your EDs day to day. But we'll just try to discuss some things and try to see that from patient's point of view, how we should change our practice so that we can give an answer to the patient. So many times we realize that when we are evaluating the chest pain, we cannot give a clear-cut answer to the patient. Though we have followed the science and the algorithm and the diagnosis tree and everything, but we cannot give a clear-cut answer to the patient. And many times there is a dilemma at the end. So how to end that dilemma, how to give a crystal clear answer to the patient, we'll try to see what we all can incorporate into our practice. So you can see on the screen that this is a chest pain evaluation. It includes all the causes, including pneumothorax, STEMI, thoracic aortic dissection, pulmonary embolism, suspected chest pain, and we are going to focus our talk today on this suspected chest pain or suspected cardiac pain. And there may be other reasons like pneumonia, pleuritis, pericarditis, musculoskeletal, gastroesophageal reflux, and psychological. But today our talk is focused on suspected cardiac pain and will mostly exclude STEMI, because once you have a STEMI, then you don't follow the chest pain diagnosis tree. So we'll proceed. So this is a 2022 ACC expert consensus decision, and you can see that they have mentioned. So I'm directly touching some topics, like I'll directly touch with the history and what are the limitations of history, then the cardiac troponins and what is the trend of using cardiac troponins, then the CT coronary angiography and all. Because otherwise the chest pain can be a full day seminar, but I'll try to touch some topic and try to see that how we can change our practice. So all the recent publications in the last 2-3 years, whether it is American or European or British, now they are recommending shortening the chest pain evaluation time in the ED, which essentially means that during the conventional troponin, when we used to do a troponin at 0, 3, 6, and 12 hours, with the high sensitive troponin, it came down to 0 and 3 hours. And now there are more high sensitivity troponins, whether troponin I or troponin T, but the companies are recommending an algorithm which is 0 hours, 0 and 1 hour, 0 and 2 hour, and 0 and 3 hours. So most of the literature now is pointing towards 0, 1 and 0, 2 hours. And there are a lot of labs which have come up with the diagnosis tree, which incorporates 1 hour and a 2-hour protocol rather than the current 3-hour which we are using, which we are using at least at our place. I don't know what other hospitals are using as of now. So this is a 2022 ACC expert consensus decision, which gives all the protocols, and you can see this is 0 to 3 hour, 0 hour single draw, this 0 1 hour rule out, 0 2 hour rule out, and high STACS protocol. So if you can see clearly that these are all criteria for rule out of ACS. Now, why all the Western literature relies on ruling out? And if you see that all their papers, they say that if you rule out, you can discharge so many patients, you can send so many patients home, you can send 60% of the patients home. So this is the requirement of their emergency departments, that they don't want to admit too many patients. They want to select clearly the patients whom they want to admit. So they are devising tests and protocols in which they can rule out, they can say that in this patient, the ACS is ruled out and they can be sent home. But in India, I believe that, at least in my personal idea and my hospital's practice is that we are not dependent on ruling out. We are always trying to rule in acute coronary syndrome. So when I see any patient with chest pain, I believe that this is a ACS unless proved otherwise, which is contrary to what the Western literature says. And this is one practice which we follow in a different way than the American, European, British, and other Western literature. So this is the European Society of Cardiology recommendation. Again, you can see at the top that is 0 and 1 hour clinical decision protocol for ruling out MI. So if you want to rule out and decide that I want to send 60% of my patient back home, then do a 0 and 1 hour troponin, and it will be negative. Even in the patients who may have ACS or who may have a significant coronary artery disease, but you can say that this is we have ruled out ACS and you can discharge them, but only that these patients will show up again, which we don't want. So as a patient, if as a person, if I go to hospital, I want an answer that do I have a acute coronary syndrome or can I have an acute coronary syndrome? And in the next few cases and few slides, we'll see that what are the logistics that the Indian hospitals, in my opinion, should work like. And you can see that this is a very complex algorithm. For each of the high sensitivity tests, which is certified according to the WHO definitions, there are different cutoffs and delta change values. So if you are using a Abbott Architect, you can find out from your lab. So if you are using a Abbott Architect HS troponin I, then you have to follow these criteria. If you are using another platform, then you have to use different criteria. So there is no single criteria for all cardiac troponin Is and all cardiac troponin Ts. It depends on the platform, the Roche, Abbott, Beckman, Siemens. So which machine you are using, you have to use the cutoffs according to that machine. So this is another complexity of using the 0, 1 and 0, 2 hour protocols. So the limitations of 0, 1 and 0, 2 hour algorithms is that they mainly depend on ruling out, and they say that they can rule out approximately 60 to 65% of individuals, rule in about 15%, and the biggest caveat is that 25 to 30% patients remain unanswered, that is intermediate risk. And in these patients, you may have to do additional testing like 3 hour or 6 hour troponin. So eventually we end up with a 0 and 3 hour algorithm, even if you start with 0, 1 and 0, 2 hour algorithms. And the European Society of Cardiology 0, 1 hour algorithm, they have written themselves that it leads to more frequent discharge from the ED, 45% versus 32%, and with a significant p-value, and 1 hour shorter ED length of stay, which is again statistically significant. So their aim is that how to shorten the ED length of stay and how to discharge more patients. The aim is not to have a correct diagnosis of chest pain, that whether this patient has ACS or whether he can have ACS. So those are not the aims. So that is the main difference between adopting the chest pain diagnosis protocols which are published in the Western literature and which we should practice in our country, in India. So what should be our aim? So if you ask me, I would say that no patient with ACS or possibility of ACS, what we call a coronary artery disease, should go home. So we are not interested in ruling out acute coronary syndrome. I am interested in ruling in acute coronary syndrome or coronary artery disease. So if a person comes with a sentinel symptom or a warning symptom, we should be able to detect whether this person has a coronary artery disease or no coronary artery disease. So if you see this a little earlier European Heart Journal article in which you say that rapid early rule in of AMI with a high sensitivity cardiac troponin, they have a 0 hour and a 3 hour protocol. So if you have to rule in, you have to use 0 hour and 3 hour protocol. If you have to use rule out, then you can go for 0, 0, 1, 0, 2 protocols. So this is the difference between the two approaches. One is rule out approach and one is rule in approach. And I would prefer that the Indian hospitals, especially the corporate hospitals, should adopt a rule in of acute MI approach, because we have to uh, give the patient the value of their money. So this used to be a chest pain diagnosis tree in our ED, and which is based on the Abbott Architect platform and the cutoff values provided by them. So we have a HS troponin at 0 hours, and then repeat HS troponin at 3 hours and see a delta change of less than 50 or more than 50, and then classify the patient. And in some patients, we can go for CT coronary angiography. You can see there CT coronary angiography at the rock bottom of the diagnosis tree. So when we all evaluate chest pains, we know that we have 3 or 4 inputs which we use in our chest pain diagnosis protocol. So first is the history, which we all take, and emergency physicians always take a quick focus history. Then we do a electrocardiogram, and that is one of the main information tool which we use in chest pain evaluation. The next is a biochemical evidence, in which we use troponins of different types: conventional troponin, high sensitive troponin, troponin I, troponin T, and all are fine. And the fourth component of input is anatomical input, in which we have to see the coronary anatomy. Now, this is the thing which personally I would promote, because it answers a lot of questions which the previous 3 components cannot. And let us see in few cases how this goes. So this is a case 1. It is a 51-year-old male. He presented with left loin to groin pain for last 30 minutes. And the clinical impression was ureteric colic. And a routine ECG was done 1.5 hours later in the ED, and it showed an anterior wall MI. And you can see the coronary angiography, there is a proximal LAD obstruction, and the diagnosis is STEMI. So the history many times may be unreliable. So it can be false positive and it can be false negative. So there are a lot of pitfalls in the history. So this is just to highlight that history cannot be totally relied, and as a single component, it can mislead. Let's take another patient. He's a 53-year-old male. He presented with severe headache. The clinical impression was migraine, and he was being treated, and a routine ECG done sometime later showed an acute anterior wall MI with an elevated troponin and a coronary invasive coronary angiography showing a triple vessel disease. So the diagnosis is STEMI. So once you add ECG and biochemical information to history, your diagnosis can change. And if you take only history, it can be misleading. So we take another case of a 55-year-old male. He presented with left shoulder pain with profuse sweating for 2 days. The first ECG is normal. You can see the first ECG on the screen. It is normal. And after 1.5 to 2 hours, we do a second ECG and it shows an anterior wall MI. So even the ECG can be misleading. So there are many ERs and nursing homes where they will do only one ECG and send the patient that ECG is normal, and actually they may be having MI in the time, and it will be left out. So the history can be misleading and the ECG can be misleading. And we know that the first ECG in STEMI can be normal in many patients. So we take another case, So this is a 46-year-old male. He is asymptomatic, went for a health checkup. The ECG was normal. The computerized stress test was normal. And he was given a report that there is no coronary artery disease. Then he also undertook a CT coronary angiography as a part of some luxury health checkup package, which showed that there is a 90% LAD. So the diagnosis changed as severe coronary artery disease, and he had to undergo revascularization procedure. So the anatomical component, when added to the information of history, ECG, and biochemical information, totally changes the diagnosis. So this is a 38-year-old male, precordial pain radiating to left shoulder and left arm for 2 days. This is a typical description of an anginal pain. The ECG showed ST elevation in inferior leads. You can see that there is a subtle elevation of ST segment in leads 2, 3, and AVF. The HS troponin was normal, but the clinical diagnosis was STEMI because of a typical pain and a ECG showing a ST segment elevation in inferior leads. Now he underwent a CT coronary angiography, which was absolutely normal. So earlier the diagnosis was STEMI, and now the diagnosis is no coronary artery disease. So the CT coronary angiography can also reverse the diagnosis. Sometimes it can give a diagnosis of coronary artery disease. Sometimes it can negate the diagnosis of ACS. So it helps in both ways. So this is a 84-year-old female, came with retrosternal pain radiating to the left shoulder for 5 days. The HS troponin I at 0 and 3 hours were 7.5 and 8.2, which were both normal. So the diagnosis was unstable angina because of some STT changes in the ECG. And she was discharged. She visited 2 days later with retrosternal pain for 1 hour. And you can see the ECG, there is already a evolved anterior MI. Her HS troponin I was 49,950. So now the diagnosis is STEMI, the same patient. So 2 days earlier, when ECG and troponins were used, the diagnosis was unstable angina. And the same patient came 1 day later with a STEMI, which means that the first time we missed the diagnosis of coronary artery disease. This is another case of 56-year-old male retrosternal chest pain for 2 hours. ECG showing acute inferior MI. Diagnosis is STEMI. But this patient visited 5 days back for chest pain. And his first ECG was normal, second ECG normal, first troponin normal, second troponin normal, delta change less than 50%. And at that time, the diagnosis was non-cardiac chest pain. And the same patient 5 days later present with a STEMI. So these are the limitations of ECG, history, and troponins. So this is an interesting case, a 32-year-old male. He comes with chest pain for 45 minutes. First and second ECG normal, first and second troponin normal. So he has already visited 1 month back and did the same thing which were normal. He had visited 4 months back also, and all these tests were normal. So what do we do now? I mean, how many more visits this patient should pay to the hospital before we give him a final answer? So this is a 38-year-old male, retrosternal pain, left arm. He's very anxious. The ECG suggests some STT changes in the inferior and lateral leads. So in this patient, we sent the troponin, but because he was very anxious and he wanted a final answer, we went ahead with CTCA even before the troponin results came, and the diagnosis was normal, no coronary artery disease. And after the patient came from CTCA, we got the troponin report that it is 4.9. And if we didn't do a CTCA, his diagnosis would have been an unstable angina. But because we did CTCA, the diagnosis is no CAD and the person can live peacefully. for few years at least. So we come back to the same question, that what do we need to answer to the patient who comes with chest pain? So everybody knows that we are always trying to look out by the history, by ECG, by troponins, that has the damage occurred. But one more question which we have to answer, that can the damage occur? So for that, we need an anatomical or a functional imaging of the heart. So functional, I am not focusing right now because that involves a stress echo and a technetium scan and PET scan and also, which I am not talking because they are not very practical and they are not very prevalent. So we'll stick to CT coronary angiography as an anatomical test. And there is a new advancement in that, which I'll talk in the end. So always remember that we have to answer two questions in every patient of chest pain: that has the damage occurred, which will be told by the ECG and the troponins. So the ECG will abnormal if ischemia has already occurred, and troponins will be abnormal if the myocardial injury has already occurred. But if ECG is normal and troponins are normal, the damage can still occur. And we have seen few patients who went with normal ECGs and biochemical troponins and came back after 2 days or after 5 days with a STEMI. So we have to answer two questions: has the damage occurred and can the damage occur? So can the damage occur can only be answered if we have an anatomical or a functional imaging of the heart. So after this, we changed our chest pain protocol. And if you remember, in the earlier chest pain diagnosis tree, we had CT coronary at the rock bottom, somewhere here. But now we have got CT coronary right on the top after first troponin. So we do a troponin at 0 hours, see the values, and then decide the CT coronary. And in fact, now we are offering all patients ECG, one troponin, and CT coronary rather than a second troponin. Only persons who are not willing or not eligible for CT coronary, we do a second troponin and then tell them to do a further evaluation. So what is the evidence for CT coronary? If you see over the years, of the last 10 years, there are a lot of papers published on CT coronary. The big ones are the PROMISE trial, the Scott Hart trial, the CORE 320, the EVINCI, the Pacific, the REASSESS trials, and all that. And they all are pro CT scan. So there are a lot of information in these trials which says that CT coronary can give a very valuable information in the evaluation of acute chest pain as well as chronic chest pain. And we'll see both of these articles in the next few slides. So this is an article published in Circulation in 2015, which shows, so the top ones are the clinical trials, which show a negative predictive value of almost 99%, which is as good as 100%. And the meta-analysis, which also shows a negative predictive value of 99% for per patient analysis, per artery analysis, and per segment analysis. So it is very accurate. So the one advantage of doing CTCA, which everybody agrees that it has almost 100% negative predictive value. So if you have a CT coronary with 0 calcium score and clean arteries, you can almost send that patient home immediately and say that there is no possibility of ACS occurring in the next 5 to 6 years, and we'll have that data in the later slides also. So this is a Singapore Medical Journal article in which they say, after doing a CTCA, that this confirms the role of CCTA as a robust first-line non-invasive diagnostic test for detecting coronary artery disease and providing essential information to guide management, therapy, and prognostic evaluation in patients with suspected CAD. So they have, in the 513 patients that they have studied, they have commented that they have confirmed the role of CT coronary angiography as a robust first-line non-invasive diagnostic test. So we were talking about what is the warranty period of coronary, and this trial says that there is a completely negative CT coronary provides a virtual guarantee of approximately 6 years of MACE-free survival. And if there are small lesions like 20, 30, or 40%, but non-obstructive coronary artery disease, it can still have a warranty period of at least 2 years. So there is this article in JAMA Internal Medicine. At the bottom, you can see the highlighted portion. It says that compared with the functional stress testing, CT coronary angio is associated with a reduced incidence of myocardial infarction. So because the people who do CT coronary angiography can get the lesion detected earlier, undergo invasive angiography, undergo revascularization procedures, be on treatment with aspirin and statins. And that is why there is a reduced incidence of myocardial infarction in patients who undergo CCTA, that is CT coronary angiography, versus the stress testing. So stress testing, according to me, should actually be given up in the evaluation of chest pain. So this is the Society of CT Coronary Tomo, Society for Coronary CT Guidelines, which says that if the risk category is high, and if the patient is already having STEMI or an unSTEMI, then they should undergo invasive coronary angiography. But all the other patients which are having risk level 3, 1, 3, 2, 1, and 0 should undergo a CT coronary angiography. And they have also laid down the degree of maximal coronary stenosis. So they say mild if it is 0 to 49%, moderate if it is 50 to 69%, and severe if it is more than 70%. So the 2014 AHA-ACC guideline for management of non-ST elevation acute coronary syndromes, it says that in patients with possible ACS and a normal ECG and normal cardiac troponins and no history of coronary artery disease in the past, it is reasonable to initially perform, you read it carefully, without serial ECGs and troponins, directly coronary computed tomography angiography to assess the coronary artery anatomy. So this is also given by the AHA-ACC guidelines. So these are the nice guidelines, the British guidelines. So they say that if you have a CT scanner above 64 slice, then CT coronary angiography is the recommended test for evaluation of recent onset chest pain. So we are talking of acute chest pain. So these are the 2019 European guideline, the ESC guideline, which says that they recommend the use of either non-invasive functional imaging of ischemia or anatomical imaging using CT coronary angiography as the initial test for diagnosing coronary artery disease. Now, this is a little complex diagram to understand, but it shows that this is the coronary CT angiography, and the red portion is the rule in, and the green portion is rule out strength of the test. So you can see that CT coronary has a very good rule out as well as a rule in for likelihood of coronary artery disease. Now from acute chest pain or a chest pain of recent onset, we come to a chronic chest pain or a stable chest pain. The 2019 ESC guidelines say that recommend the use of an imaging diagnostic test instead of exercise ECG as the initial test for diagnosis of obstructive coronary artery disease. So they also say that CT coronary is better than doing an exercise ECG or a stress test for evaluation of coronary artery disease. This is the American College of Cardiology 2018 guidelines for stable chest pain, and they have also told that CT coronary angiography is the recommended test for such patients. So these are again the 2019 ESC guidelines in a graphic way, and in which they have given a whole section for CT coronary angiography. Now, one thing which people always fear is the radiation in CT coronary angiography. But the modern machines, which are faster and delivering or rendering less radiation to the patient, you can see the comparison. The CTCA leads to 2 to 7 millisieverts of radiation, whereas a stress thallium, which is a functional imaging of the heart, um, renders 4 to 10 millisieverts of radiation. And a typical angiography with angioplasty and stent, renders 14 to 20 millisieverts. So if you do a CT coronary, it is far less radiation than the other tests, which are recommended for evaluation of uh, chest pain, ACS, or coronary artery disease. So it is pretty safe. Now we come about the cost. I mean, is it cost effective to do a CT coronary? Now you can say that in the routine care, if you do 2 troponins, actually it should be 4,000 because 2,000 is the cost of 1 troponin. So if you do 2 troponins and 1 chest X-ray and other tests like stress thallium and do a 2D echo over 1 or 2 days, then the cost would be something about 25,000. But if you do a CTCA, it costs 20,000 rupees. Okay. So it is more time effective and it is cost effective with acceptable radiation exposure, and gives a very valuable information about the existence of coronary artery disease or not. So as I told you, what is the future advances in CT coronary? So we can see that the newer CT scanners, as well as the newer software, they also add a functional component in addition to the anatomic imaging. So it is a combined anatomic functional imaging. And in functional imaging, I mean that they are able to measure the fractional flow rate of the coronaries beyond the obstruction. So the anatomical imaging will only tell it is a 30% or 40% or 60% obstruction. But the FFR, which is also done in the invasive coronary angiography, is now possible in CT coronary angiography, and they can actually say whether it is a significant obstruction or not, and refine the decision making process for patients with coronary artery disease. And I believe most of the hospitals, where corporate hospitals in private sectors who have high-end machine, they must be doing the FFR in addition to the simple anatomical imaging of the coronaries. So in the conclusion, I would say that we should aim to rule in rather than rule out acute coronary syndrome. And we should always answer 2 questions: that has the damage occurred? And we can use ECG and troponins for this. But if ECG is normal and troponins are normal, we still have the second question remaining, that can the damage occur? And that can be answered only by functional imaging or anatomical imaging. Now, the functional imaging is a stress test, which a lot of papers have said is it's of no use and not recommended. Now, between the anatomical and stress CTCA and stress thallium, CTCA is a more practical test, easily available. We get reported fast. It takes about less than 5 minutes on the CT gantry to do the CTCA as compared to stress thallium. And stress thallium is more or less not very popular test for evaluation of chest pain. So at the end, some points in favor of CT coronary angiography incorporation into the chest pain evaluation in the ED. It is a high diagnostic accuracy. It rarely misses severe high-risk coronary artery disease and is almost as 100% negative predictive value. It reduces major adverse cardiac events. The procedure is safe, fast, and cost-effective and time-effective. That reduces the ED time, the length of stay of patients, and at the end saves life. Because we have seen that many patients who were labeled with a normal ECG and normal troponins as non-cardiac chest pain turned out to be a critical LAD stenosis. So knowing that a person has a critical coronary artery disease and undergoing timely treatment is a life-saving procedure.